let me give you the 2-cent tour of who I am and why I'm chatting with you guys about this. So I'm a medical doctor, and I trained in medicine in a very traditional fashion. I went to Harvard Medical School. I trained in internal medicine at the Brigham Women's Hospital, which is a big, relatively well-known hospital in the Boston area. And then I went on to practice medicine in the emergency department at the VA up in the New England region, where I was for at least 15 years. And then that sort of led me to becoming a cannabis specialist, which, if you think about it, given the fact that I work for the federal government, is kind of an odd transition. But what really happened was that I had spent so many years taking care of these veterans whose lives in many aspects had been really harmed by alcohol primarily, but also various other drugs, both prescription and illicit, and really had sort of become kind of an expert on treating these illnesses, just because, by trial by fire, right? Because, here they are in your emergency room, and sometimes they were there for these drugs or alcohol related problem, but sometimes not that at all. They were there for some routine care type thing, but then you would find that whatever you were trying to accomplish for them was, ran into this drug and alcohol problem as a roadblock. And so having sort of developed this expertise and maybe even interest, when Massachusetts in 2011, 2012 started talking about medical cannabis as an option, because they had a ballot initiative, I sort of went, it's funny that I've seen all these guys who've been so harmed by these various other substances, and yet never seen anybody who is sick from cannabis. Maybe if that's true, I should be looking into whether there's really some medical value or not. And that really led me to reading the literature, and, from a fairly skeptical point of view, coming out the other side of which really understanding that there is quite a bit known about the way cannabis works and what it can do for people. And then, there's this sort of common discussion that you'll see in the news where people will say, we just don't know enough about this, and there's not enough data and all that sort of thing. And frankly, I kind of came to appreciate that kind of remark is more of a political statement than a scientific statement. And I might go so far as to say it's kind of a political dodge. There's no question that we can use more information about cannabis. On the other hand, we are continuing to do research in cardiology, and it doesn't mean that we don't treat people who have heart disease using the best information that we have at the time. So anyway, after I kind of had come to this understanding of cannabis as a medical agent, I sort of looked around the landscape, and clearly I wasn't going to be able to do this within the VA, but what I realized was that not only did very few physicians know much about this, but that even the private institutions like the Brigham Women's Hospital that I mentioned, because they receive federal funding for almost everything that they do, we're setting policies that said, no, we're not going to do this because we're afraid the feds will cut off our money. So I thought, how am I going to help my patients and also my physician colleagues take care of these patients? And so I said, look, I'm going to start a private practice. I never really set out to be in private practice, but it was a way for me to be outside the system enough that I wasn't being controlled by it in this manner. But also then, because I was connected into these systems, I then started giving talks, much like the one we're doing today, to my colleagues to help them understand that there was value there, and also that I hadn't completely flipped my lid. And gone off the ranch, and that there was actually, we could work together on this. So that's kind of the why and the how I got here. Now we'll see if the slides comply. So, one of the things that we need to understand is a little bit of the historical context, and I imagine that you guys have talked a bit about this. And, this is sort of a little timeline here. I'm used to having a laser pointer so I can point at things, but we'll just muddle on through here. Cannabis has been used for thousands and thousands of years. We have evidence of cannabis use in ancient Egypt, in ancient China, in some of the Eastern European tribes dating back to sort of 5,000 to 6,000 years ago. The uses of cannabis have been varied throughout this period of time. Some of it has been medicinal. Obviously, some of it has been recreational. In temperate climates like Western Europe, frankly, cannabis really never caught on very well, largely because it doesn't grow into what we think of as cannabis in temperate climates. It tends to grow into what we think of as hemp, which doesn't really have much in the way of medicinal value, but has lots of value in terms of sort of economic growth and fibers and building material and other sorts of agricultural products. The fact that cannabis has been used for thousands of years often gets used by cannabis advocates and enthusiasts to say, look, it's been used for thousands of years and we don't have any records of problems and such like that. And I think that, as an erudite group, you guys can look at that and say, well, it's true that we have lots and lots of years of experience, but people didn't think about science and medicine the same way for the vast majority of that period of time. So to say that, this thousands of years worth of experience really equates with science is probably pushing the bounds of reality a little bit. Cannabis did, however, become used medicinally in the West back in the 1830s. There was a gentleman physician whose name was O'Shaughnessy, who was an Irishman in the service of the Royal Army, who was sent to India to observe and to treat the troops, and he became quite an expert on cannabis medicine because in India at that time there were uses which still would sort of probably stretch our imagination for medical, but he brought cannabis and the concept of cannabis as a medicine back to the West, where it had to be grown under special circumstances to get, actually, most of it was then imported from India. But this was really the beginning of our understanding of it from a truly medical point of view. Cannabis was then used throughout the 1800s, both in Europe and then in America for medical purposes. Prior to O'Shaughnessy's introducing this as medicine, frankly speaking, we knew all about hemp. You've probably read about the fact that hemp was grown for rope fiber, and it was considered un-American during the American Revolution not to be growing hemp for the war effort. But that was hemp, and it wasn't used in a medical fashion. We used cannabis as medicine throughout the later part of the 1800s. And a couple of things that really kind of started to change that. One was the invention of the hypodermic needle in the late part of the Civil War brought about the interest in morphine because it's water soluble and could be injected. And though morphine and cannabis sort of coexisted, and then as you can see from the slide, it became illegal in the 1930s, sort of as alcohol prohibition was weaned. There was a large government agency that was tasked with beating up on people for alcohol, and if they were out of a job, they were not going to be happy, so they came up with this idea that we could beat up on people over cannabis, and particularly we could go after Hispanic immigrants, which was a large political issue at that time, and that sort of thing. So it became illegal in 1937 over the objections of the American Medical Association. In 1970, or in the end of 1960, Timothy Leary, whom you've heard of, I'm sure, won a Supreme Court case in which the Marijuana Tax Act, which was the bill from 1937, was overturned. And literally 2 months later, the Nixon administration had already in place the Controlled Substances Act of 1970, which then created the Drug Enforcement Agency to oversee this and also coerce the FDA into banning this stuff. We talked a little bit about how much evidence there really is at this point. You know, if you go to PubMed and you put in cannabis, you will find that there are over 26,000 studies, making it, I think, the most studied substance ever. And just for comparison's sake, it's worth pointing out that alcohol sort of turns out to have about 5,500 studies. So, you know, if you compare those, you can see there's quite an impressive number on cannabis. A 2012 UK study, which really tried to look at the Controlled Substances Act, or the British version thereof, and really go back and use the medical evidence for how we should rank these controlled or potentially harmful substances. And, you know, and the take-home message here, which is not really surprising, is that both alcohol and tobacco have far more serious consequences and far more evidence to support those consequences. Is everybody hearing me okay?
Yeah.
Excellent. So this is my scary slide. And really what this is not really intended for you to get deep into the biochemical pathways that are drawn out for you there on the left side. At least I assume it's your left side. But really to get into the point that cannabis works for a reason. And the reason is that we have this endocannabinoid system. And it's there, and it's part of us, and it has a job to do, and it is a complex system that involves multiple enzymes and multiple receptors, some of which are cannabinoid specific, that bind with our own internal or endocannabinoids, and they're an important part of cell regulation. And that furthermore, the system itself is interesting because unlike some of the other systems that we knew beforehand, like the dopaminergic system, the serotonergic system, the acetylcholine motor system, those are all kind of primary effector systems, meaning they have a job to do and they're the system that does that job. And we can see the outcome of their efforts when we can move an arm and a leg. But the endocannabinoid system is really what we would call a meta system. It doesn't really do anything like moving arms and legs. It's a system that spans the other systems and kind of keeps it in balance, in regulation. And so people talk a lot about the endocannabinoid system being responsible for maintaining homeostasis in the organism, which, if you think about it, makes a lot of sense that there's crosstalk between these systems. But it also makes a lot of sense that until we started looking at why cannabis works and then discovering the receptors and trying to figure out how the receptors are working and where they're located and all those sorts of things, that we wouldn't actually have ever found this. So now that we know what it is, we've been able to kind of get in there and understand how this works. Did something change? Because I'm suddenly getting a lot of feedback.
No, it's the same.
Same? All right.
Yeah, nothing changed on our side.
All right, well, maybe it's just their computer. Anyway, so the point is that, you know, one of the comparisons people like to make is, you know, regulate cannabis like alcohol. And from sort of a political point of view, I can see where they're coming from, and it sort of fits with their sort of libertarian point of view on what people should be able to do with cannabis. But from a physician's point of view, from a medical point of view, this stuff has specific utility, and that we should be able to employ it in a way that really is beneficial. And so, you know, on a political level, I think it's important for us to kind of provide tools that we can use to achieve those. But one of the reasons why I think that alcohol is a very poor comparator is because alcohol doesn't have any medical benefit. Alcohol, if you think about it, is really a poison, right? it is something that in small doses we find enjoyable, but in larger doses it tends to kill us. And the reason that is because, well, to be blunt about it, alcohol is yeast poop, right? It's a byproduct of their respiration. And so when we take this stuff into us, it is not good for us. And in small doses, we can tolerate it and even enjoy it. But but it doesn't interact specifically with a set of biological systems. It simply makes the systems generally kind of not work very well, and for a brief while at low doses, that's enjoyable. But cannabis, on the other hand, interacts with a specific set of receptors and biological systems. That means that we can use these exogenous or phyto from plant-derived cannabinoids for specific purposes. And that's, I think, really the thing that makes that comparison not very apt. So when people start to talk to me about cannabis as medicine, the first things that they bring up are all their objections. And so this slide is starting to talk a little bit about some of those objections. And the first objection that people come up with is, but it's addictive. No, it's not addictive. We have to remember that dependence is not the same as addiction. And dependence, for which there is some evidence in, regarding cannabis, is about a biological or physiologic need that develops so that if you withdraw the substance, your body complains to you. Essentially, you have withdrawal symptoms, and we can see that there are many medications that do that sort of thing, and I listed the SSRIs as an example, and then some sort of more far-flung or sort of extreme examples of things like food and air and water. The point being is if we do without any of those sorts of things, that we have a physiologic negative reaction. And yes, we can see that sort of thing in a percentage of people who use cannabis. Addiction, on the other hand, really is a set of maladaptive behaviors that arise around the use of a substance that then have a negative impact upon the quality of the user's life and the people in, the important people in that user's life. And what we see in cannabis is we don't see that. So whereas, we see people who use opiates knocking off liquor stores, we see people who use alcohol beating their spouses, we don't see that sort of maladaptive behaviors around cannabis. The lifetime risk of dependence for cannabis, actually the number that I list here of 9% is out of date. The best understood numbers at the moment are around 7%. And people say, oh, well, that's 7%. But I often say, but that means 93% don't have this problem at all. And if you want to compare this, you want to compare this against a 32% for nicotine, which we all know is the most addictive or dependence-forming. See, I slip into the vernacular too. But 32% for nicotine, which is the most dependence-forming substance we know, 23% for heroin, 17% for cocaine, and 15% for alcohol. So, alcohol is basically twice as habit-forming as cannabis is. The other thing to note about this set of statistics are that it doesn't tell a full story, because when you look at lifetime risk, that's risk over one's full life. And those numbers for all of the substances that are not cannabis are sort of a constant or level risk, meaning if you're 25, your risk of problems with heroin is about 25%, and if you're 45 or 65, it's still about 25%. But cannabis, in fact, turns out to be different, and the risk is primarily front-loaded, which leads us to a lot of the discussion you've heard in the media and in the political arena about trying to keep teenagers and maybe even young adults away from cannabis, because their risk of dependence is closer to 17 or 18%, but that after the age of 25, that risk drops down to 2 or 3%. So that in fact, we may want to set both medical practice and social policy with some eye to the age of onset of use, because that in fact may mean something. And then the other thing that one really has to ask anytime one looks at the risk of dependence, for example, is, okay, this is the risk of becoming dependent, but also what is the risk associated with the withdrawal, right? Okay, if I become dependent, how bad is that for me, right? And so we know, for example, that withdrawal from heroin is a very, very unpleasant and protracted affair with sweating and pain and vomiting and wishing you were dead and all of those sorts of very unpleasant things. On the other hand, heroin cold turkey withdrawal will not kill you. So that's kind of in the plus column, minor thing in the plus column. Whereas, and I didn't put this on the sheet, but benzodiazepines, which also work out to about 17% in the dependence department, if you stop them abruptly, you can develop seizures and in fact die. So the risk of the dependence is really two factors. What's the risk it might happen, and what's the risk of what will happen if it does happen? And so the question is, what does marijuana withdrawal look like? And for the most part, it looks like a fairly minor set of symptoms, usually sort of around 3 to 7 days of irritability, insomnia, sort of just general kind of crankiness. Which, is probably no fun to endure, and it's certainly no fun to be around, but it's, in stark contrast to the withdrawal from opiates or the withdrawal from benzos. Now let's talk a little bit about what you can actually do with cannabis. Pain control. It turns out that cannabis can be used to control pain. Now, the interesting thing about this is that pain is a hugely pervasive problem in the United States. It is the number one complaint of patients to their doctors, and it is also the number one thing that the patients tell us we're really not doing a very good job of fixing or treating. And we are certainly seeing the outcome of this in the so-called opioid epidemic. It's unclear why it is that Americans have so much pain, but it is understood that we have something like 20% of the world's population and use 80% of the world's opiates, and clearly that's some sort of a mismatch. And we know also that opiates are dangerous, and in particular in a linear fashion, meaning the more you're taking, the higher your risk. So the question then becomes, what could we use for pain control other than opiates? And it turns out the answer to that is not much. When we really think about what we have to use to treat pain, we really only have 3 classes of agents. We have Tylenol, right, which lives in a class by itself and can be useful for minor pain, but has its limits. And then the second class are what we call nonsteroidal anti-inflammatories, which includes aspirin, Motrin, and naproxen, and a whole bunch of other medications, but they're all fairly similar and they fit in this category called nonsteroidals. And they can be very useful also for pain, but they also have some downside risk. They can cause bleeding ulcers, they can cause kidney failure, and a few other issues. So some people don't get enough relief from either of those two classes, or they get sick from them, or they have some contraindication. And so when you're done thinking about those 2 classes, you're left with the third and last class, which is opiates. So you can understand that you can blow through those first 2 sets of options very quickly and arrive at opiates as, the last choice. So what we really need to address both pain and the opioid crisis are more options that work. So enter cannabis. It turns out that opioids are really not super good pain controllers for chronic pain. So if you need to have an operation, which will cause you acute pain, opioids are a great thing. But if you have chronic pain, which means pain that is defined as ongoing for greater than 3 months, then opioids, they do okay, but they're not great. And then they come with all the baggage of all that risk. When we look at cannabis, it too isn't super great as a pain reliever. Um, it's actually about equal to that of the opiates. But then you sit back and you say, well, look, if I have two things I can treat somebody's pain with, and they're equally efficacious, albeit neither of them are brilliant, but one of them is really dangerous and the other one is really not, well, which one should you pick? And I think that becomes kind of a no-brainer, siding on the side of cannabis. So that's one thing we can address. Depression and anxiety. This is where, things in the lay world kind of get fuzzy, and we've all probably heard about how you can go to or used to be able to go in California pretty much anywhere and find some kind of a quack in the box who would say, you could say, I can't sleep or I have anxiety, and you could get a piece of paper that would let you smoke all the weed you wanted. And I think that that's a very unfortunate circumstance, because it's denigrated the patients, it's denigrated the medicine, and it's denigrated the practice of medicine. But, that is the way that was. But it turns out that we can, in fact, get mileage out of cannabis for both anxiety and depression. And what's also very interesting is that people who typically use cannabis for these things use way too much and way too often. But if we take a very modest dose, and we dose it in the evening so that we're not being intoxicated during the day when we need to do our things, it turns out that this can be very beneficial for both depression and anxiety. And there's some really interesting molecular studies coming out now that are leading to our better understanding why this works, and also the ways in which it turns out that at least unipolar depression may be more related to schizophrenia than to bipolar and manic depression than we previously thought. Um, so let's see, is there more to say on that? The other thing I would say is that while it's reasonably good for anxiety, as an antidepressant, it tends to be fairly weak in its action. So that if a person were to come to me and say, "Yeah, I'm feeling depressed and I've not taken anything," then cannabis might be a reasonable treatment. If they come in and they say, "I'm taking, a starter dose like 25 milligrams of Zoloft," then it might be a reasonable substitute. But really, if they're on any higher levels of these medications, then it's really not a very viable substitute. It's just not potent enough to do what we want. On the other hand, patients often come in and they say, "Look, I'm on, 100 milligrams of Zoloft, and actually my depression is somewhat better, but I've sort of lost the joie de vivre, the joy in my life has gone out. So the lows aren't as low, but the positives aren't as positive, and I kind of feel the word people use is, I feel like a zombie." And it turns out that if you then add cannabis as an adjunct to their SSRI, some of that joy in their life comes back. And so you can use cannabis sort of not to directly treat the depression, but rather to offset some of the downsides from the medicines that are treating the depression. So, we can, with caution and thought, get a lot of mileage out of this stuff. Insomnia is really interesting. May not be obvious to you guys, but insomnia following pain is the number 2 complaint of Americans. And again, sort of the number 2 complaint that they say, "Doc, your medicines just aren't doing it." And again, it's one of these areas where we don't have a lot of choices. We can give people Benadryl, and sometimes that works. And in elderly people, that has side effects that may complicate things. And we've got benzos, which have obviously the risks that we've kind of talked about. And then we've got Ambien, which, some people like, and other people find that it gives them a terrible hangover. So there are some choices to use, but none of them are perfect. And I would say of all of the diagnoses or symptoms that we are talking about today, insomnia is the thing that cannabis does best of all. And so we can give people a tiny little dose before bedtime, and that often fixes a whole range of problems. Now, insomnia tends to fall into sort of two categories. There are the people who have trouble getting to sleep, and then there are the people who have trouble staying asleep. And insomnia of the getting to sleep variety is very easily treated with cannabis. It's a little bit harder with the staying asleep folks because you have to figure out how you're going to dose this in such a way that they don't wake up the next morning feeling kind of sort of still hungover. So if they wake up at 2 in the morning and they need to get up at 6, then another dose of cannabis at 2 is probably just fine because the duration tends to be about 4 hours. But if it's, 4 or 5 in the morning and they need to be up at 6, then you have to really think twice about how you're doing that. Again, this is why having people know what they're doing is kind of helpful for patients. Anorexia. Let me point out that anorexia is a medical term for difficulty eating, and not simply anorexia nervosa, which is an eating disorder that is most closely related, in fact, to OCD. And so when I'm talking about anorexia, I'm talking about poor appetite, difficulty eating, either for unclear reasons, or lifestyle issues, or disease-related issues, or disease treatment issues. And certainly, I think we all think immediately of people on chemotherapy where they have such horrible nausea and vomiting, which I think is the next bullet point, actually, and who then need some help being able to get past those negative symptoms and then even actually beyond that to feel interested in food. Cannabis can be extraordinarily useful for those sorts of things. Interestingly, people who don't have anorexia often ask me about getting fat because of the munchies and what can I do about the munchies? And the answer is, the munchies are kind of another side effect that comes with it. And so I tend to prepare my patients with some, practical tips, which really kind of boil down to fill your house up with baby carrots rather than Doritos, which seems kind of like a no-brainer, but the point being is that you probably will go after that which is sort of crunchy and chewy. And so if you have more healthful foods around, then that's a good thing. And the other interesting thing is that, and I'm not entirely sure what we make of this, but several studies now have shown that long-time recreational cannabis users on average have a lower BMI than the American general population, which is a little reassuring. It also then leads to some very odd headlines in the press where people say, cannabis prevents metabolic syndrome. Really? So, there's no evidence for that other than to say that, cannabis users on average seem to be less fat than the average American. And I don't think you can draw a conclusion beyond that. We talked briefly about nausea and vomiting. We should mention for a moment that while cannabis itself remains federally illegal, there is a federally approved, prescribable variation on cannabis, which is a synthetic THC called Marinol. And Marinol was approved for use with chemotherapy-associated nausea and vomiting in the late 1980s and was in use through the early 1990s. But frankly speaking, it didn't work super well, and most people who took it opted out very quickly. And part of the reason that we believe that's the case now is that what we've come to understand is that cannabis is a complex set of chemicals that interact with our neurology, not simply being one chemical. And so Marinol is a synthetic single agent THC. One of the things we know is that one of the other chemicals in cannabis that's not THC is called CBD, cannabidiol. You guys have probably heard a lot about it. Most of what you've heard is probably not true. because it's enduring or enjoying, I should say, a popularity at the moment that I think is undeserved. But it is an important part of the group of medicines, what we call the entourage, that accompanies THC. And we know that one of the things that CBD does is it binds to the CB receptors, the thing that THC interacts with, but it changes that receptor to modulate the reaction it has when THC comes along. And so patients, when they took Marinol, would say, I'm just getting super high and it's horribly unpleasant and I'm not enjoying it. It's not helping with my nausea and vomiting. And this probably would have gotten explored in more depth scientifically, except what happened then was in the early 1990s, a medicine called Zofran or ondansetron came along, and it's quite frankly better than any kind of cannabis for nausea and vomiting, and sort of knocked Marinol off the shelf, so to speak. The nice thing is that, in fact, now that we're using whole flower cannabis and its derivatives, is that we can use Zofran and cannabis and do even better for our patients. Sexual dysfunction obviously doesn't get a lot of talk in our society. It's a huge problem. 30% of men over a lifetime will experience some sort of sexual dysfunction, 40% of women. I don't want to get too deep into this subject because it really is its own hour's worth of conversation. But, one of the things we have to understand is that in the current medical armament, we have one medicine that works for one problem, which is erectile dysfunction in men, and it does nothing for any of the other problems that men might experience, and it doesn't do anything at all for women. It turns out, however, that with careful dosing in men, and less importantly so in women, we can in fact use cannabis to address a whole range of sexual issues for the better. And I think I'm going to leave it there. The other way of thinking about this is in terms of disease states. So we know that there are certain neurologic issues from which we can get benefit. Multiple sclerosis is kind of the poster child here, where we have seen both sort of anecdotal as well as good scientific studies showing decrease in spasticity and pain using various cannabis or cannabinoid preparations. There's really growing evidence now for CBD, which I mentioned earlier, in children who have these rare genetic seizure disorders like Lennox-Gastaut and Dravet syndrome. And there's some evidence now that it can be used in a sort of neuroprotective, it meaning cannabis, in a neuroprotective fashion for other sorts of degenerative neurologic diseases. Alzheimer's disease is sort of one of the many in that category. And Parkinson's would be sort of another. I think that all of that data is extraordinarily preliminary and may in fact turn out to be a little bit of wishful thinking, but remains to be seen. Autoimmune diseases, we've seen some fairly convincing evidence in Crohn's disease for down modulation of the underlying autoimmune process. We're starting to see some evidence that this also applies in other inflammatory bowel disease like ulcerative colitis, and also in non-bowel related autoimmune disease, being like rheumatoid arthritis as an example. Now, again, you have to kind of step back and divide this into, like, are we treating pain, which is legitimate, but are we also actually doing something that modifies the underlying disease, meaning the inflammatory and the destructive processes that are either going on in these folks' bowel or in their joints? And, I think it's fairly clear, again, that we can modify the pain. Whether we're really modifying the underlying autoimmune disease, I think, is still up in the air. But there are a number of studies at this point that actually make it look like, make it there's fair amount of positive evidence that we can actually start to modify those diseases themselves. And just as an aside, some of the best evidence in Crohn's disease for the anti-inflammatory component of cannabis turns out not to be THC, and it turns out not to be CBD. It turns out to be THCA, which is THC acid, which is the non-psychoactive precursor of THC, which we don't hear a ton about, at least in the lay world, largely because it doesn't get you high, and that's part of the discussion, but also because whenever you cook or burn or vaporize cannabis, that decarboxylates the THCA into THC. So we have most experience with the THC because it's what we get if we're not going out of our way to make sure that we extract the THCA without applying heat. So we're just sort of starting to get around to doing studies with some of these more carefully prepared cannabinoid components. And I think that the entirety of pharmaceutical investigation is going to be changed as we come to understand cannabis and all of its components, both because there are so many ways in which they interact with our body, but also because the way they interact is dependent upon the other chemicals or some subset of the other chemicals that are in cannabis, that entourage. And we're very used to in a pharmaceutical model that looks for one chemical. And if we can then start to wrap our head around medicines that are comprised of multiple chemicals, how many medicines make me discover that we didn't even know to look for because we were so focused on looking for one agent? So leaving cannabis aside as the source of medicinal agents, I think that if we can simply understand cannabis, we're going to discover things unrelated to cannabis that we would just kind of run right by in our current way of doing the investigations. People are very eager to treat their cancer with cannabis. I have patients come to me every week, multiple, with this as their goal. And you know what I tend to tell them is, look, we have some very encouraging, very preliminary evidence that cannabis in various forms can kill cancer cells. But we also know that it depends a little bit on what's in that cannabis, and it also depends on what type of cancer it is, and those factors make a difference as to whether it will or won't do what we want. And also that all of those studies have been done in the test tube, and occasionally in the mouse. And that really doesn't rise to the level of evidence that we would expect for any kind of a medicine for human beings. I got to the point several weeks ago where I asked myself the question, what percent of medications that look promising in animal studies then fail in human beings? And I actually went and looked up this number, and I nearly fell off my chair when I found it because it's enormous. It's 92%. Let me repeat that. 92% of all the medicines that look good in mice don't work or kill people in human beings. So all of that evidence that it kills cancer in test tubes and in mice, I don't know what it means. When my patients ask me, will I help them with this? What I say is, as long as you understand how little evidence there is for this at the moment, and are willing to continue your conventional proven therapy, as long as your oncologists are willing to keep going with you, then because cannabis is so non-toxic, I'm willing to take this journey with you, but it has to be under those circumstances and with that understanding and agreement. And generally speaking, that works pretty well, and my patients have been doing pretty well overall. I have had an occasional patient come in and say, no, I want to use cannabis instead. And I think the most sort of notable one is I had a 42-year-old woman who had papillary carcinoma of the thyroid, which is an entirely curable, not just treatable, curable disease, what you need is to remove the thyroid. It's a surgical procedure, but once it's done, you're done. So this was a 42-year-old woman with 2 children under the age of 5 who had an entirely curable cancer who wanted not to do the surgery, but just to use cannabis. And believe me, I told her I thought that was not a good idea and I wouldn't participate. And I strongly urged her to go back to her surgeon. And I unfortunately never heard from her again. So I hope that's because she went off to the surgeon and got fixed, but I don't know the answer to that. And that's not there. You guys have probably heard an awful lot about strains and CBD. And what I think is that at the moment, we don't have enough evidence to substantiate the claims that strains are important. And let me clarify that. I think that anybody who's used cannabis in any fashion will describe that different types of cannabis provoke slightly different sets of reactions or feelings. And some of them may be more pleasant than others. And so people certainly can experiment with different strains and find ones that they prefer over other ones that they don't prefer. But the word prefer or preference, I think, is exactly the operative word there. And it really becomes a question of, whether you like pizza with or without pepperoni, but it doesn't really change the outcome, which is that if you eat the pizza, you get fed. And so my observation, and the literature at this point mostly supports this, is that the differences between these strains may lead to preference, but not to a significant medical outcome difference. Now, what I just said is a little bit at odds with some of the data that I mentioned about the anti-cancer properties, because we know in those cases, some of these strains are more effective for some cancers than others. And so I think ultimately we're going to understand this better on the level of which chemicals are doing what and which ones are really necessary and which ones are just sort of along for the ride, but we're not there yet. And so in some ways, what we have to do is work with what we have while exploring further. And one of the things that I see as an unfortunate consequence of this strain game is it has become kind of a marketing tool for the dispensaries to sell more cannabis to otherwise sort of unsuspecting patients. And that, to me, is a big problem. CBD, which, as we mentioned, is a second cannabinoid that comes with cannabis. It's been purified, and it's been used now to try to treat basically anything and everything. Its major selling point is that it's non-psychoactive, which for some patients is an issue, but mostly for politicians that is an issue, because there is inherently something wrong in our national psyche about having a medicine that causes intoxication, which is, of course, odd because many of our medications cause various kinds of intoxications, and usually they're negative, whereas this one tends to be, by and large, more positively experienced. But nonetheless, the point about CBD is that where we have found it to be useful is, again, in treating those seizures of the very rare children who have uncontrollable seizure disorders. But it's worth noting that those children's seizure disorders do not really give us reasonable evidence to generalize to other children with unexplained or non-genetically related seizure disorders, and certainly an enormous leap to say that it should be used to treat adults with, unexplained seizure disorder. But that, of course, is what people are claiming at this time. And it's also interesting to note that the use of CBD in those children with the rare genetic disorders tends to work for only about 6 months. And after that, its effects tend to wear off unless you add a little bit of THC into that brew, and then it starts to work again and continue to work. So there's clearly, again, evidence for the interaction between these chemicals. People talk on the adult front about CBD being useful for anxiety and even for pain control. And these are all based on animal studies, and we know what those are worth. But the other thing that's worth noting about them is that the animal studies use doses of CBD that are 10 times what any human can afford, number one, or are using while they're running around saying that CBD rather has changed their lives. So the inference that I draw is that CBD is a very expensive and popular placebo at the doses that we're using. And I can also tell you from personal experience that CBD at these higher doses, where we would expect it to actually be efficacious, is actually fairly unpleasant in and of itself, just not in the same kind of reaction as you would get from THC. There is a lot of discussion about using the ratios of THC to CBD to reduce the intoxication caused by THC. And the most recent set of studies actually confirm that this is not really true. And that, a 1-to-1 THC to CBD mixture will get you just as high as a, plain old ordinary THC preparation. On the other hand, maybe it is that people feel less high because they actually take less THC because they're getting less per puff or hit, to use the vernacular, and they're used to taking 4 puffs of high THC strain. Now they're taking something that's half THC and half CBD, so then they're getting half as much THC. I don't know the answer to that. That's just conjecture. But the point being is that what we do know is that by bumping up the CBD, we are not actually undoing the THC side effects. This is a little bit about, this slide isn't super relevant for your class, but I would just kind of get to the point that I want to make overall, which is that certification or getting your card, man, isn't really the goal. It may have been the goal in California when people were going to the Quack in the Box and getting their paper, et cetera. But that's really not sort of medical, even though it's called medical. Really, that's recreational masquerading as something where the law will allow it. But when we really talk about practicing medicine with cannabis, we need to remember that the focus needs to be on patient care, not on the prescription, essentially, on getting the medicine. You don't go to the doctor saying, I want lisinopril. You go to the doctor saying, I'm concerned that maybe I have high blood pressure. What do you think? What do we do about it? How do you use the medicine? All that sort of stuff that goes along with care, not just here's the medicine, go figure it out. I mean, this is a huge problem right now, is that the culture around medicine in medical care is this sort of weird thing where the doctor says, yes, you can have it. And then the patient is supposed to walk out the door and sort of figure it out. Worse, yet they're supposed to get their advice from a bunch of lay people who have, not a lot to back up their points of view other than the fact that this is the way they do it. Or they're getting it from the dispensary who have no more knowledge than the lay people, but they have every reason to sell people stuff because they're in the business of selling stuff. And then, of course, I think it's also very important that we think about, seeing people back, right? You can write a prescription for this stuff for up to a year, at least in Massachusetts, and I think that's true in Florida. No, in Florida, you guys have to renew every 45 days or something. And that's a plus, right? I mean, what that means is that the patient and the physician need to engage in an ongoing relationship around, are we making you better? And that's what medicine is about. So anyway, that's a little bit on my soapbox. Not that any of this isn't on my soapbox. Let's see. How are we doing on time? I just don't want to take up too much time. All right.
We have another hour, and I guess we'll have some time for questions. Well, because you're answering a lot of the questions that came in on that other PowerPoint, so this is good.
Okay, great. So I'm actually closing in on the end of the slides, and then we'll do the Q&A stuff.
Perfect.
One of the things that's really important about cannabis as a medicine is understanding the available routes of administration and how they're different. And, in medicine, we're sort of fairly used to giving things as pills, by and large. You know, there are some other medicines we give IV, and you know, and there are some that are inhaled, but really the vast majority of them are pills. And I don't know whether that's good or bad. That's just kind of the way it is. But one of the things we need to understand is that just like conventional medicines, treating patients with cannabis requires careful attention to dosing, but also to the ways in which the route of administration changes the behavior, both in terms of the blood levels, or the rate of rise and decay, right? What we would call the pharmacokinetics, and also having to do with the way that we metabolize cannabinoids. So, you know, as with my patients, I always start to talk about smoking. And the interesting thing is that despite many, many years of looking for the kinds of harms from smoking cannabis that we would expect based on smoking tobacco, we have not yet found those harms, which I find somewhat reassuring. But it's also true that, you know, the time course, while lengthy, is probably not lengthy enough. And so I start by talking about smoking, I don't in general recommend that people actually smoke this stuff. But smoking, if you think about it, is a form of inhalation. And inhalation has certain advantages over other forms. Or maybe it's not even advantages. Maybe it's just it's different, and we can use those in certain circumstances advantageously. And so when we inhale this stuff, the onset of effect is relatively rapid, right? It kicks in not instantly, which is what you'll read on the web, and that's a really good way for people to overdose because they think it should be working and they take more. But it's, 10 to 15 minutes it starts to work, and that's a fairly short time to onset. And then the other thing is its duration of action tends to be sort of modest, meaning 3 or 4 hours, and then it starts to wear off. And so for many things, that is a great way of doing things. For example, if you have the anorexia that we were talking about, and you need to sit down to a meal because it's lunchtime, you might want 10, 15 minutes beforehand to use this medicine by inhalation to stimulate the appetite at mealtime. But similarly, you might want this to work during lunch and then not necessarily kind of have, leave you intoxicated for the entirety of the rest of the day. So the fact that it wears off after a fairly short while is, again, another advantage. So when we want to use those advantages, but we don't want to smoke, then we turn to something like a vaporizer. And if you can see the pictures there, to the right of the woman smoking the joint is a device with a straw sticking out of it, and it has kind of like fins and stuff, and that is Storz & Bickel crafty flower vaporizer. So the top comes off that thing, and you put ground up cannabis material in it, and then it heats that material to a temperature where the cannabinoids come off as a vapor that we can breathe, but it's nowhere near the temperature of burning, so we get no smoke. And that becomes the ideal way of providing the medicine when we want inhalation. Downside to the machine is that it's a machine, and therefore it costs money up front when you have to buy it. This particular machine costs $279.
Hear that with CPAP and so forth. That's
right.
I hear a lot of.
Say that again?
Because I talk sometimes about the dangers of where they're selling the oils, but not all the time do you know what is in the oil if you're not getting it from a dispensary or if you're not making it yourself. And a lot of times those little pins are getting sold around where you just buy those little cartridges filled with the oil. So do you have anything to say on that?
Yes, I was absolutely going to get there. So you are absolutely correct that when oils are made, and first of all, I really hate the word oil because it really isn't actually an oil, and it gets used both for the inhalable forms and the edible forms. But leaving that aside, the oil cartridge can, if it's made poorly, contain heavy metals and pesticides. which could be in the cannabis too. But the point is you're using a large amount of cannabis and concentrating it down into this form, which means that you are concentrating these impurities as well. But it also turns out that even if you get oils from a reputable and well-intentioned source like the dispensaries, they're still dangerous. And the reason for that is that the cannabis concentrates are too solid to be put into the pen cartridge. So they need to be diluted in something. And the typical thing that people used to use was propylene glycol or polyethylene glycol, which are both used in common foodstuffs, but they're not heated at the time that they're used. When you heat those chemicals, they convert into formaldehyde, which, as we know, is not very good for you. And so the next thing that people are doing is they've stopped using PG and PEG, and they're using terpenes, which are the sort of aromatherapy type chemicals that come from cannabis. And the issue there is twofold. One is we're using them, when you use them to dilute the cannabis, at much higher concentrations than they exist in cannabis. And since we think that they're potentially biologically active chemicals, we don't really have any data to say that that's safe. The other thing is that when you overheat those terpenes, they can convert into carcinogens called acrolein and metaacrolein. And these pens are not sophisticated enough to hit and maintain a specific temperature. So the flower vaporizer above, you set that to a temperature, typically 350 degrees Fahrenheit, and it has a microprocessor in there that monitors that temperature, so it gets to 350 and it stays there. Whereas the pens are basically just a coil, a battery, and a switch, so that the more you puff on them, the hotter they get, and we have really no idea and no control over what their maximum temperature is, but it's a fair bet to guess that it gets to the point where we're starting to convert these terpenes into bad things. So I don't recommend these pens at all. And in Florida, where you guys at the moment are not allowed to use ground flower, I think that presents a number of problems. The other thing that people use is medium-chain triglyceride oil as a diluent, and we know that inhaling MCT oil can be harmful to your lungs as well. So there really haven't been a ton of great options for making these oil-type pens work safely, which is why I point my patients back to plain old flower in a flower vaporizer, which frankly I admit is not as easy to use and it's not as sexy and discreet. But if we're thinking about this stuff from the point of view of using it medically as opposed to recreationally, I find that the sexy factor is just sort of less compelling. Let's see. Then we can go on to talking about cannabis that's taken orally. And this is one of those areas where, you know, in the lay world, people start talking about, well, if you don't want to smoke it, you can eat it and this stuff and the other. And that really is a misunderstanding of the way this behaves, at least from a medical point of view, because it behaves radically different when you eat it than when you inhale it. When you take it orally, it takes a long time to kick in. And worse than that, it's variable and unpredictable about when it will kick in. So that maybe one day it starts to work after an hour, but the next day with the same patient and the same preparation of medicine, it's 2 hours. So you really don't know what it's going to be, and you don't know when it's going to work, and you can't seem to predict it. It doesn't seem to be about hydration. It doesn't seem to be about what you've eaten that day. It's just, we don't know yet. And maybe we will figure that out. I imagine we will, but we haven't gotten there yet. And so for certain circumstances, that level of unpredictability is okay, but not for others. So if you have the onset of a migraine-type headache, taking an edible, which is going to work 2 or 3 hours later, is probably just not the right idea. Whereas taking a couple of puffs on a flower vaporizer is going to work when you need it. The other side of the edible equation is that once it starts to work, it works for much longer, more like 8 to 12 hours, as opposed to the inhaled stuff being more like 3 or 4 hours. So we can use the oral stuff as sort of a long-acting form of the medicine. And for certain pain control-oriented situations, that's exactly the right idea. So if somebody comes to me and they have episodic pain, doesn't hurt except when it hurts, right? Then that person is unlikely to be benefited much by these oral things like we just mentioned with a migraine. They're going to do better with that inhaled stuff. On the other hand, if you have somebody who comes in and says, Doc, I'm in pain 24/7, I'm, ready to knock myself off, I can't get comfortable, it's all the time. What I think is, look, if that person is so uncomfortable that being comfortable but buzzed, meaning intoxicated, all the time is better than the way they are now, then an edible makes a lot of sense, because then you're not taking it episodically, you're taking it by the clock, which overcomes the issue of delayed onset and takes advantage of the benefit of the prolonged duration. And frankly speaking, when we really start to think about this in sort of the palliative pain care mode, the combination of an oral with the inhaled makes the most sense, where we use the oral on the clock to, develop some baseline pain control, but then certain times, certain activities or whatever, that pain may escape, right, break through, at which point then you would take an extra dose using the inhaler or the vaporizer. And that is a rubric that works really very well. Briefly, I want to mention tinctures and topicals. Tinctures are a liquid form of cannabis extract, and the current mythology is that you put this stuff under your tongue and hold it there, and somehow it will be absorbed through your mouth into your bloodstream. And I would point out that mouths are made for chewing food and swallowing food, and not for absorbing food. And so there's really not very good reason to think that it would be absorbed this way. And now we have data that shows that the absorption of cannabinoids through the mouth is trivial, basically non-existent. So what happens is people put this in their mouth, they expect a certain reaction, they get that reaction, which is not because of absorbing cannabinoids, but because of what we call the placebo effect, right? You expect it, you feel it. Then they swallow this stuff, and then it gets absorbed just like it was an edible, or actually not as well, because it's not, tinctures and oils are not absorbed as well as edibles are. But the point being is that whole rubric is flawed, and I tend not to use them because of that. And then topicals sound like such a lovely idea. It's, Doc, my knee hurts. Can I rub this stuff on my knee and feel better? And so the answer to that is interesting. Yes, you can rub it on your knee and maybe you'll feel better, but it isn't because of the cannabinoids. So we have really good evidence at this point that cannabis doesn't go through your skin, which is true for most medications, which is why we don't deliver most medications through the skin. Yes, we can use fancy pharmaceutical type tricks to make it go through the skin, but those often come at the cost of developing rashes and such, or hypersensitivities, that one might ask, why bother? If there have been some really good studies on the placebo effect that show that you can give somebody any kind of goop that has nothing in it, and if they rub it on their sore knee, they're going to get some benefit. And that's a plus on some level, but again, it doesn't have anything to do with the cannabis. And that little white tub of cream that's in the photograph there in the dispensary would cost $80, whereas if that were some over-the-counter just plain old skin moisturizer, it would be $5. So when we think about what's the value or how much we want to get into the business of employing the placebo effect, we have to really think about our patients' wallets a little bit on their behalf, because frankly this stuff is just incredibly expensive, and God knows most folks have other things that they need to spend their money on. Dosing, we've talked about this a lot. Dosing is really crucial, right? As you can see in that graph, right, as you add a dose of something, you get to a point where you're getting the sweet spot, which is maximal benefit before you go over the edge of that curve and you start to get just more side effects. And this isn't true just of cannabis. This is true of all medications. It's why medications come in doses. And that we use doses sort of from a starting range to a maximal range, because we know that going beyond the maximal range, we're not going to get better benefit. We're just going to start to see side effects and harms. So that the same is true with cannabis. And so on the bottom of the slide, we see this little hot leaf where it says 10 to 15 milligrams, and that's because, generally speaking, my patients seem to get best benefit in that 10 to 15 milligram range. And through various means, both inhaled and orally, we can achieve a specific dose. But what we don't want is sending grandma home to do bong rips, right? Like the picture. Because that's not really going to help her. And I will tell you that I have had patients who, for whatever reason, didn't listen to me, and they went to the dispensary and got told a whole bunch of hooey, that then they go home and they do it the way they got told, and then they call me the next day and say, oh my God, doctor, I feel so sick, what happened? And then I talk to them and I figure out that they didn't dose 10 to 15 milligrams, they dosed 85 to 100 milligrams. They didn't know any better because they were misled by somebody who wasn't really thinking about them properly or not thinking about their best interests properly. In fact, just over the weekend, I had a patient email me, actually on the plane down here, saying that he had started his anti-cancer treatment and that he had gotten so overwhelmed and sick that he had felt the need to call an ambulance, and he was taken to the hospital and he was kept overnight, where, you know, obviously all they did for him was watch him, because there isn't anything more that you need to do. But when I asked him, well, what happened? How much did you take? Well, it turned out, you know, I said, look, this is the target dose we're going for. I want you to start way down here at this little beginning dose. And we're going to work our way up to the target dose over many weeks. And he did start below the target dose, but he started at about 30% as opposed to 10%. So it's not entirely surprising that he felt sick, although I'm a little surprised because he was actually, a previous user of cannabis. So the point being is that you have to really pay attention to what you're doing. This is my summary slide. So prohibition we talked about was largely a political and financial consideration. We now have great safety data. We have more safety data on cannabis than on any other medication that is federally approved and regulated. Certainly, you know, lisinopril and Lasix and all of those commonly used medications have not undergone nearly the kind of long-term scrutiny that cannabis has. We have found that cannabis is reasonably effective for pain and certainly a lot safer than many of the other options which are limited. That it is effective for a range, or preliminary evidence suggests that it is effective for a range of neurologic and immune illnesses. That the route of administration is an enormous factor in how this stuff will behave for people. That strains are overly talked about, but probably don't matter a whole heck of a lot, at least at the level of specificity that we have at the moment in terms of medical outcomes. I would like to take a brief moment to mention the Association of Cannabis Specialists, which is an international organization that I founded, which really aims at educating clinicians, both cannabis specialists themselves, as well as people we would call referring doctors, and also has a strong aim toward making sure that the cannabis products that are made are what we need for medical care, and that dispensaries are treating patients correctly, and lastly, that the political arena, the federal government, gets called to task over its current obstructionism with regard to both using and researching cannabis as medicine. So if you guys are of the mind to check out the Association of Cannabis Specialists, the address on the web is cannabis-specialist.org. And, no, I didn't even realize I had these bullet points. Oh, there we go. just to say what I just said. There it is. Ah, see, I didn't even know that there's PowerPoint is a funky, funky program. It's good, but it's not so good. Anyway, and then we have my favorite picture, my Mr. Happy Veteran. And if you want a bunch of references, you can go over here to this URL and download a lot of stuff. If you are interested in checking out my practice, there is my website, and you can always email me with questions at the email that's listed there. And that's, I think, pretty much the end of what I had prepared to talk to you guys about. So now, let me take a sip here, and you guys can fire away.
Wow, you guys, that is a lot. All right. You guys overwhelmed yet with that information on cannabis? So a lot of the questions were answered. I mean, the ones that, so basically, like I told you, I had copied and pasted the questions that you guys had posted, sent them to him, so he had this already prepared for us, and then integrating that with the questions that you guys had. So I think one that I had not heard was like the mangoes, and that goes, he mentioned about like terpenes and so forth, so awesome about that. But questions, specific curiosities. I see one over here. Yes, ma'am.
Do you think that legalization of cannabis for recreational use will have a negative effect on the growth and improvement of the medical cannabis industry?
Are you able to hear us?
Yes, it's quiet, but I think I got it. Let me repeat the question, and then you can tell me if I got it right. She asked, do I think that the legalization for recreational use will have a negative effect on medical advances in cannabis?
That's right.
I think the answer to that is yes, and it's something that I and the Association of Cannabis Specialists are very keen to prevent. Not to prevent legalization for recreational use, but to do it in a thoughtful manner such that patients and recreational users, who are really, if we think about it, kind of different groups of folk, can have access to what they need or want. Right now, the unfortunate thing that's going on sort of politically is that there are a number of groups out there that I would call cannabis political activist groups, and their modus operandi is to go into a state and create a campaign around, usually a ballot initiative, to get medical cannabis approved. And they always write the bills in a way that actually looks fairly different from Florida, where the limits on the amount of cannabis are enormous, and the control aspects that physicians have are extraordinarily limited. And what they then do is, once they get that passed, then they start pushing on expanding the list of conditions, which is another issue I think we need to get away from, and essentially just trying to make it so that anything becomes considered a medical condition. So what that does is it strengthens the dispensary industry because it provides more and more customers. And then the next step is they go back with a recreational ballot initiative and say to the public, look, the sky didn't fall with all these people out there using it medically, so let's just legalize it recreationally. And then if that passes, you end up with something that may look like Washington State, where they essentially said, well, now that we've legalized it for everyone, let's just forget about the whole medical thing, and everyone's kind of a recreational user. And that's problematic because it stands in the way of getting proper dosing and more research, and it also emboldens or empowers the dispensaries, whose job it is really just to sell this stuff, to sell it to people who are patients and therefore are sort of a different class of folk. They're folk who are looking for a specific outcome. They have real illness. They have lists of medications that they may be on that the dispensary not only doesn't know about, but doesn't really have any training to understand, even if they did know about it. And so one of the things that I've really come to understand is that I think that most Americans think that prescriptions are written by doctors to control them, the patient. I'm going to write out a prescription for 90 days worth of this medicine, and you need to take one pill every day because that's what I told you to do. And there is some truth to the idea that it is a means by which the physician communicates how this medicine should be best taken. But we also all know that 64% of people take their medicines in some manner other than what the doctor actually intended. That was an eye-opening study from about 2-3 years ago. But the point I actually have really come to understand is that the prescription is far less about controlling the person, the patient, and far more about controlling the seller of the medication. When you go to a pharmacy with a prescription, they sell you that medicine, but there's no wink, wink, nudge, nudge, would you like a side of Percocet with that, right? Because they're legally constrained not to do that. And the dispensaries are not. So if I send my patient to the dispensary to buy, say, 1/8 of an ounce of cannabis flower to use with a vaporizer, the dispensaries are empowered to and do start talking the patient up about, oh, you should buy some CBD. Why don't you get a chocolate bar? Here's some quiche, which is a concentrate. Oh, don't you want to get a vape pen? You know, and so I may be sending the patient in to get a very specific, small, low-cost amount of something, and by the time they're done at the dispensary, they walk out with $250 worth of stuff that's either junk to them or worse yet is going to make them sick. And so getting into a situation where actually Florida is better in that there is a specific order written to which the dispensary is beholden, that's something that has, that Florida has done really well and really uniquely compared with the rest of the country. Most of the rest of the country is really much more of a free-for-all for those dispensaries, and that's not a good thing. So we're working on changing that, and we need to change it at the federal level. But that's, part and parcel of a much larger fight. Beyond what's happening with the president and AG, the other question becomes, how do we legalize it? And this really gets me back to that Trojan horse mentality that I was talking about a while back, is that if we get to full recreational legalization by the means that these groups want to put forward, then what they want to do is treat it like alcohol. So they want to take it away from the DEA and away from the FDA and essentially make it like alcohol, which would be under ATF. And I think it's a little weird to take something that is illegal away from one group of cops and give it to another group of cops. But their idea is essentially we get a national unified policy, which is essentially whatever you want to do as long as you pay your taxes, that's okay. And I have a problem with that because that prioritizes recreational users over patients and gets back into that whole discussion of, does recreational pose a threat to the advancement of medicine? And what I think is going to have to happen for this to go well is for us to come up with a rubric that does kind of both. It says, look, we're going to have a cannabis system that looks kind of more like the Florida system, where doctors can write an order and patients can go and get that order filled at a dispensary. On the other hand, or simultaneous, and that's constrained and specific, and in a way that the current prescribing system for other meds exists. And maybe the answer is ultimately it will be sold through a pharmacy, which is what I think it should have been in the first place. And so it doesn't have to be on the Controlled Substances list. There things that are not on the Controlled Substances Act are still controlled. They're just controlled by the FDA itself rather than through the DEA under the Food, Drug, and Cosmetic Act of 1934. So I think that's where cannabis needs to go in part. And then there may be another way in which it then goes to ATF or some other administrative group that says, okay, but if you're not using this for medicine, then you can get it at a retail outlet, a retail shop, for whatever purpose you want to use it. But that's not controlled the same way. It probably has different types of products, and it also isn't allowed to make any medical claims. So right now, dispensaries and retail outlets in states that have retail outlets say things like, this kind of cannabis will be good for your anxiety, or this will be good for your back pain. And I think that those things should be forbidden, because the people saying them have no idea whether they are or they aren't. They have no idea of what the consequences to any individual patient might be of using that product, and they have every financial motivation to say things that are somewhere between loosely true and or not true at all. So again, what I would like to see is that anybody who says, look, I want to use this for medicine, they should go see their doctor and get a true, proper medical interaction that leads to a true, proper prescription for a true, proper medicine. And then if you want to get stoned, you can go down to the corner and get yourself a spleef and have at it, but the intentions there are different. And I think in large measure, the populations of people who would be in one of those systems or the other are mostly non-overlapping groups of folks.
I think one of the most important things it's all important, but there's one conversation we had regarding how the actual getting high, how that in the reality is a side effect, not an intended outcome or a desired, like, I'm going to smoke because I want to get blitzed. But yet, and when you said that, man, that stuck with me, because that's something that is this kind of stereotypical frame of mindset that people think that, I'm just smoking because I'm getting high. But when you really are talking to people who are using cannabis for the appropriate and legitimate reasons, just like whenever we take a certain pill and we get dry mouth, or we take an opioid and take a Percocet and we itch, there are these side effects. I'm not taking a Percocet because I want to itch. I'm not taking my Ritalin because I want to have dry mouth. And so that's that kind of this mindset that hearing it from a physician and having a legitimate conversation about this type of stuff while we're not, under an oak tree, that's the difference of. And so when you speak to that a little bit of just, because that, I think, wrapping up to letting them hear that from a legitimate point of view, to me, I know that was powerful. And then even working with my own clients to have to break through that, I don't want to be high. Well, that's a side effect, not the desired outcome.
The reality is that the ingredients that are going to do the benefit do cause intoxication. And so therefore, it's not the intended effect, it's a side effect. And we have to manage that side effect like we would manage the side effects from any other conventional medication. But it is very much fundamentally a different point of view of what the intention is and why there's a need. And, in some ways, patients come to me and they say, Doc, I just want to feel like me again. My life is being taken over by the pain or the, fill in the blank there. And we're just trying to get them back to sort of normal for them. They're not trying to get high. They're just trying to get through their day. And it's a very different set of needs from somebody who, also legitimately is saying, look, I just spent the last 6 hours taking an exam and I'm beat and I want to just kind of get blitzed and eat Doritos and watch television. I don't have a problem with that. But it's a different need or desire, and and so when we're thinking about medicine, we really have to think about what it is that we're treating. And if, by the way, there's a side effect of some intoxication, then we have to acknowledge that and manage it and not be so afraid of it also that we then discount or block the use of an otherwise helpful medicinal agent.